Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, welcome back. Today, we're going to be doing a comprehensive overview of all things pneumonia. This is going to be kind of a foundational basics overview lecture on pneumonia. We'll be talking about what it is, the epidemiology of it, how many people get it, how to diagnose it, the differential diagnosis for it, the different infectious organisms that can cause it. We'll talk about treatment modalities. We'll categorize it into community-acquired, hospital-acquired, ventilator-associated. We'll talk about prognosis, some tips and tricks, some kind of clinical anecdotes from yours truly, and we'll go from there. For those of you new, just a couple shameless plugs. We apologize. This study guide, as well as practice questions, will be uploaded to our Patreon page, as it is for all of these videos. We also have a YouTube members page with early access and a weekly newsletter. All that will be linked in the description. We also come up with everything in podcast form and YouTube video form, so check those out if you have an interest. No further ado, shameless plugs completed. Thank you all. Let's dive into pneumonia. So, defining pneumonia, okay? Pneumonia is an infection. That's a good start, all right? And it's an infection of the lung parenchyma, or the lung tissue. It's most typically caused by bacteria, viruses, or also fungi, although we don't think about that as much. And it results in inflammation and then alveolar consolidation. So let's dissect some of this a little bit. It is an infection. I think we probably know that, right? We already talked about, is it bacterial? Is it viral? Is it fungal? So it is an infection. It's not, the pneumonia we're talking about is not autoimmune. It's not vascular, it's an infection. It's an infection, though, of the lung parenchyma. When we think about the lungs themselves, if we kind of just draw what looks like a pair of lungs, hopefully, for those of you listening to this in podcast form, we just drew a trachea, bronchi, and then two lungs. In the lungs, there are bronchi, bronchioles. These are all airways, right? This is what oxygen and air travels through to the alveoli. So if we zoom way in, we get these bronchi into bronchioles that go into these kind of small balloon-like structures that are alveoli. For those of you listening to the podcast, we just did a really bad drawing. We're almost happy that some people are just listening to this. And these alveoli are surrounded by tissue, right? This kind of interstitial tissue here. So when you get pneumonia, it's not necessarily infection of these windpipes, these bronchi. It's infection of the alveoli and the surrounding tissue, the lung parenchyma, all right? And it causes inflammation, and it causes these alveoli to collapse. And when they collapse, they can't exchange gas. And when they can't exchange gas, you get low oxygen levels, you can get high carbon dioxide levels, all that good stuff. And this is why it causes hypoxia or hypoxemia, this alveolar consolidation. All right, certainly a simplistic representation of the pathophysiology of pneumonia, but an accurate one nonetheless. When we think about epidemiology, how many people this affects, it's actually one of the most common infectious causes of hospitalization and death worldwide. So this is hugely common. In our clinical practice in the ICU and the emergency department, we see patients with pneumonia every single day, much more than we, wish occurred, because this is something that people battle. Now, it's not always bacterial. It's sometimes viral. Even more rarely, it's sometimes fungal, although that's much less common. But this is one of the most common infectious causes of hospitalization and death worldwide. So it's really important, really, really important. The highest risk groups, the people who suffer the most from this, are adults age 65 and older, and then children less than 5 years old. So, the old and the young really can suffer the most from pneumonia. Anybody can. Young, I guess we'll change this to the very young, the old and the very young. Anyone can get pneumonia, get sick from it. We certainly have seen that, but really the very old and very young do a lot worse. Immunocompromised patients, as with any infectious disease, are much higher risk. If you get pneumonia and you're immunocompromised, maybe you've got an organ transplant, so you're on immunosuppressive therapy, or maybe you have an autoimmune or rheumatologic disease, so you're on kind of immune modulating drugs. You're at much higher risk to get very sick from pneumonia. And then those with chronic diseases also are higher risk. We see this in our patients with COPD, heart failure, respiratory or poorly controlled diabetes. And this is if you have lung parenchymal disease like COPD, you are at higher risk for pneumonia. If you have poorly controlled diabetes, you're at higher risk for all sorts of infections. And if you have comorbidities, you're at higher risk to get sicker from these things. And we'll talk about this a little bit when we talk about some of the risk stratification tools like CURB-65 and the Pneumonia Severity Index score and all that. Okay. We also have a couple different definitions of pneumonia. The first is CAP, Community Acquired Pneumonia, CAP, C-A-P, Community Acquired Pneumonia. And this is when you're just out in the world doing your own thing and you get pneumonia. You get it from the community. But there's also these entities, and these change over time. And, some of this isn't as mainstream anymore, but there's hospital-acquired pneumonia, which is pneumonia that you develop actually while you're in the hospital, after 48 hours from admission. And then there's ventilator-associated pneumonia, meaning you've been on a ventilator, and if you've been on it for more than 48 hours and you develop pneumonia, it's ventilator-associated pneumonia. And the reason these are important is because the organisms that you're at risk to have caught that are causing your pneumonia are different, right? If you're out in the world doing your own thing, you're exposed to different bacteria and viruses than if you're in the hospital, being exposed to a bunch of sick people, or if you're on a mechanical ventilator where you can't really cough up things the way you typically do, right? All that can affect the bacteria that you're most prone to getting. And that transitions into etiology or causes of pneumonia. Again, the first type of pneumonia we talked about was community-acquired pneumonia. This is pneumonia you're just getting from the community. You're just a normal person living out in the world. And the most common pathogen in general, the most common bacteria for community-acquired pneumonia is Streptococcus pneumoniae, strep pneumonia. This is most common just in general. Many people who get community-acquired pneumonia have strep pneumoniae. Haemophilus influenza is another bacteria that causes pneumonia, and this is kind of classical for test, most often seen in patients with COPD or emphysema or obstructive lung disease, Haemophilus influenza. Mycoplasma pneumonia is what we call an atypical organism causing pneumonia, not because it doesn't cause pneumonia, but the way it does it is a little bit different. It's similar to chlamydia pneumoniae. Both of these cause atypical pneumonias. These are usually milder, okay? They can happen in kind of young adults, and the treatments are a little different, but they don't often cause as severe disease, which is why they're known as atypical pneumonia. So streptococcal pneumonia, Haemophilus influenza, Mycoplasma pneumoniae, chlamydia pneumoniae, not to be confused with chlamydia that causes the sexually transmitted infection. Another one is Legionella pneumonophila. We just call it Legionella, so we don't even know if we pronounce the other word right. This is another one that can cause pneumonia, and this is the most classic kind of pathodrome with this. It's contaminated water. Nursing homes, even hospitals, sometimes have outbreaks where they get contaminated water in their sinks or air conditioning units. Usually causes higher fevers. GI symptoms are more common in Legionella pneumonia, and then also hyponatremia or a low serum sodium is more common in Legionella pneumonia. And then there's a whole slew of respiratory viruses that can cause community-acquired pneumonia. Influenza, respiratory syncytial virus, SARS-CoV-2, adenovirus, et cetera, et cetera. There's tons of respiratory viruses that can cause pneumonia. Different hospitals have different abilities to test for these. Pretty much every hospital probably has the ability to test for influenza, RSV or respiratory syncytial virus, and then SARS-CoV-2 or COVID-19. Most hospitals probably have a more expanded kind of respiratory pathogen panel, RPP, that can test for a lot of these respiratory viruses, but still not all of them. So sometimes it's tough to pin down the exact virus. But yes, streptococcal pneumonia, most common, Haemophilus, most kind of typical in COPD patients, Mycoplasma and chlamydia pneumoniae, atypical pneumonias, milder course, young adults, Legionella, often associated with kind of contaminated water, GI symptoms, and low serum sodium, and then a whole plethora of respiratory viruses. That is kind of our community-acquired pneumonia. There are some fungal pathogens that can cause community-acquired pneumonia, blastomycosis, histoplasmosis, coccidioides. There's a whole bunch of other ones, but these are very uncommon. Most people have to have some degree of lung disease or immunosuppression or just get super unlikely, but it is possible. So hospital-acquired and ventilator-associated pneumonia, you'll start to see that the pathogens that can cause this can be a little bit different. You're more likely to have kind of a more severe resistant pathogen, things like Pseudomonas aeruginosa, associated with structural lung disease, Staphylococcus aureus, or even MRSA, methicillin-resistant Staph aureus. We spelled correlation wrong, our apologies. There is kind of a test association with MRSA and post-influenza. So you have the flu, you're starting to get better, then all of a sudden you start to get worse, thick cough, trouble breathing. There is some clinical correlation with post-influenza pneumonia and Staph aureus. Gram-negative rods, things like Klebsiella, E. coli, and Enterobacter are more common for hospital-acquired or ventilator-associated pneumonia. This is probably bridged from some degree of aspiration because these are more GU and intra-abdominal organisms, but if you're aspirating that into your lungs, you're more common to get a gram-negative pneumonia like Klebsiella, E. coli, or Enterobacter. And then fungi can be more common for hospital-acquired, but particularly things like Aspergillus. Again, we talked about how blastomycosis and histoplasmosis is often in immunocompromised hosts rather than those who are on the ventilator. There's not a lot of blastomycosis living in the hospital to get infected with, but aspergillosis can be. But the organisms you worry the most about when someone has pneumonia that's hospital-acquired or ventilator-associated is Pseudomonas, Staph aureus, particularly methicillin-resistant Staph aureus, and then gram-negative rods like Klebsiella, E. coli, and Enterobacter. All right, differential diagnosis for pneumonia. These things are fairly straightforward, but they're still really important to talk about. And one of the differential diagnoses that can be hard in a patient who looks fairly well is acute bronchitis. Unlike pneumonia, bronchitis is itis of the bronchi. Itis being inflammation, bronchi being the airways, so it's inflammation of the airways. And these are those patients that have cough, but their chest x-ray is totally clear. They don't have any focal consolidation on their chest x-ray, their lung parenchyma looks good. And this is often just inflammation of the bronchi, bronchitis. It's mostly viral in origin. It doesn't need antibiotics. It can certainly be really annoying for patients, but it is not a kind of focal pneumonia. Heart failure can cause pulmonary edema, right? Pulmonary edema is fluid on the lungs. It can lead to crackles on exam, kind of diffuse interstitial infiltrates on x-ray. They'll often have cardiomegaly, an enlarged heart on x-ray, and an elevated BNP, brain natriuretic peptide. Might be some hints that it might be heart failure. Pulmonary embolism, or PE, can be mistaken for pneumonia at times. PE is often more sudden in onset, whereas pneumonia progresses over days. A lot of the pain in pulmonary embolism is pleuritic. It's pain with deep breaths. Now, you can have pleurisy with pneumonia too, so don't put too much stake in that, but PE is often more pleuritic. And then think about risk factors. You know, different people are at risk for PE as compared to pneumonia. There's overlap, but there are some different risk factors there. Lung cancer is a big one that can be mistaken for pneumonia. Now, lung cancer can cause a post-obstructive pneumonia, but lung cancer in and of itself. Usually lung cancer symptoms are progressive and chronic. Hemoptysis or bloody sputum can sometimes be more indicative of lung cancer, but you can also get hemoptysis with a PE, and you definitely can get hemoptysis with pneumonia as well. So maybe we'll even cross that out. We've changed our mind. Weight loss is more common with lung cancer, so more chronic symptoms, things like weight loss. Now, there are some pneumonias, sometimes we abbreviate pneumonia, PNA pneumonia, that are more kind of subacute to chronic. A lot of fungal pneumonias can be subacute to chronic, or some of these bacteria that are more indolent. So they can sometimes cause chronic symptoms and weight loss, but much less common. Tuberculosis can cause, excuse us, a pneumonia type picture. Tuberculosis we put as a separate beast here because it's not, pneumonia as we talk about, and the treatments are totally different. Night sweats, often upper lobe predominant. So on imaging, usually tuberculosis affects those upper lobes, and you can have a chronic cough. COVID pneumonia, this is part of the normal pneumonia differential, but we put it on there. And then aspiration pneumonitis. This is sometimes a really hard thing to tease out because aspiration pneumonitis can sometimes turn into real bacterial pneumonia, but if you aspirate, if you choke on your gastric contents, that's a bunch of acid. That's going to cause inflammation in your lungs, and it can be really difficult to determine, especially someone who's been in the hospital for a little bit, and now they get some worsening hypoxia. They have some infiltrates on their chest x-ray, but the nurse is like, oh, whenever they eat, they seem to be choking, and you're like, gosh, is this aspiration pneumonitis versus pneumonia? It can be really difficult to tease out, but something to keep on the differential. Okay, clinical presentation of these things. So symptoms of pneumonia are things we often think about, right? Fever, cough, it can be dry, it can be productive, dyspnea or shortness of breath. Again, you can get pleuritic chest pain or pleurisy with pneumonia, and fatigue, right? These are somewhat generic symptoms of respiratory infection. All right, some of these are just from being sick. Some of these are specific to the lungs. When you're auscultating them on their lung exam, they can get crackles, rales, bronchial breath sounds, dullness to percussion if there's an infiltrate and consolidation, increased tactile fremitus. We're gonna we're blanking on the word. We are going to tell everybody, although that's not the word we're going to use, that we have over time put much less stake in things like tactile fremitus and dullness to percussion, because we have ultrasound and imaging modalities to detect pneumonia. But these are classical physical exam maneuvers. And the physical exam is really important, so don't listen to us. But yes, we don't use those clinically that often. And then elderly patients often can present with kind of general encephalopathy or delirium when they have an infection in general, pneumonia being one of those things. So we go to diagnose pneumonia. A lot of times we use chest x-ray as a diagnostic modality to look for an infiltrate. This is a chest x-ray to the right. For those of you listening to this in podcast form, there's this kind of dense consolidation on the right upper lobe, right? You can see that this is all kind of dark and black in color. This is dark and black in color, and this is all white. So that's a kind of a dense lobar consolidation. Okay, sometimes it could be more patchy on both sides or one side. Lots of different features. Now, chest x-ray sensitivity for pneumonia is not 100%. Okay, chest x-rays can miss pneumonias. There's been different studies on this. It's tough to say what's the gold standard, but when they've done both chest x-ray and CT, CAT scans of the chest on patients, the chest x-ray does not pick up on nearly as many infiltrates as the CT chest does. So if someone has a really convincing story and their chest x-ray is negative, we're not suggesting you dish out antibiotics like candy, but chest x-rays can sometimes be negative, even in pneumonia, so just keep that in mind. Different laboratory tests that can help guide you. CBC with a leukocytosis or a high white count with a left shift. We love the phrase that the white blood cell count is the last refuge of the intellectually destitute, so don't put too much on the white blood cell count, but leukocytosis can be suggestive. There's a lot on CRPs or C-reactive proteins and procalcitonin. Procalcitonin, PCN, procalcitonin, is usually elevated when it's a bacterial cause and usually is not elevated when it's a viral cause. There's a lot here. There's lots of different discussion guidelines, literature. Probably not worth us diving into it here, but procalcitonin should not be used to decide if you start antibiotics. There's some evidence potentially that procalcitonin, when you trend it over 24 to 48 hours, could maybe be used to stop antibiotics early. But again, all those phrases are kind of loaded phrases. Sputum culture and gram stain, if they have a productive cough, you can certainly send that off for culture. Blood cultures, if they have moderate to severe illness, so someone with kind of mild pneumonia who you're sending home doesn't need blood culture, someone who's super sick that you're admitting to the ICU does. And then really you should do these viral studies, COVID, flu, RSV testing. But the big thing with pneumonia diagnosis is history. Imaging can be helpful, but it's not absolute. And labs, really aren't often that helpful, but you should still do them. Okay? Risk stratification. So if someone has pneumonia, there's some tools that we can use to help us understand if they're high risk to get super sick or if they maybe are okay to go home. The most mainstream one is this CURB 65 score. We often use MD-Calc. We don't get any, endorsements from MD-Calc, although as we said before, that would be nice because we use it a lot, but MD-Calc is the CURB 65 score as well as a lot of these risk stratification tools. You just Google MD-Calc and it'll pop up. But essentially you get a point for each of these criteria. So if the patient's confused, they get a point. If their BUN is elevated, they get a point. If they're tachypnic, point. Hypotensive, point. If they're elderly, they get a point. And then down here, through different studies, they've kind of categorized based on how many points someone has, whether they're safe to go home or they need to be admitted. And if they have 0 to 1 points, outpatient treatment is recommended, so they're stable to be treated at home with oral antibiotics, assuming it's bacterial. If they have 2 points, you really should admit them, but just general medical floor. If they have greater than 3 points, you should admit them, but really kind of observation of the short stay unit. If they have more than 3 points, Hospitalization on the general medical floor, if they have more than 4, you could consider something like an ICU. This is a little more broken down than is typical, but the general features here are reasonable. So if you just did the math, let's just say someone, quote unquote, is just 70. So that's the only point they get. The rest of these are negative. It would be 1 point, and that 70-year-old maybe could be okay with outpatient treatment. But if they were 70 and they also had a BUN that was elevated, that would be 2 points. And maybe they need a short stay. But if they're 70 and they had a BUN that was elevated and they were also tachypnic and hypotensive, that's 4 points. Maybe we should really think about the ICU for that patient. So CURB 65 can be a stratification tool to help us understand the safest way to treat the patient. Again, not medical advice, certainly do your own learnings on things. The other one is called the Pneumonia Severity Index. This is on MD Calc as well. This is incredibly long and complex. It calculates a mortality risk using tons of variables: age, vital signs, labs, comorbidities. We actually use the Pneumonia Severity Index maybe more than we use CURB 65. We just didn't want to put the whole thing on here because it's super, super long. But again, you could just look it up, Pneumonia Severity Index, and you could fill that out and help understand the mortality risk for patients with pneumonia, which is nice. Okay, getting into treatment now. If they're going home, there are outpatient treatment regimens, okay? If they're healthy, they have no recent antibiotics, they don't have a lot of comorbidities, honestly, doxycycline or even azithromycin as monotherapy is not unreasonable. Some people use amoxicillin as well. If they do have some comorbidities, you can't really get away with just this regimen. You really should do a combination. You can do something like amoxicillin clavulanate, also known as Augmentin, with a macrolide like azithromycin or with doxycycline, or you can use a fluoroquinolone, levofloxacin, moxifloxacin as monotherapy can be used too. But people with comorbidities or risk factors shouldn't just get monotherapy, whereas those healthy without comorbidities and no recent risk factors can usually be okay with monotherapy. If you do have to admit patients, the regimen changes a little bit. So admitted inpatient but not going to the ICU, we often do a beta-lactam like ceftriaxone mixed with a macrolide like azithromycin or doxycycline. So it's usually ceftriaxone plus azithro. If their QTC is prolonged, which azithromycin can prolong the QTC, we usually sub in doxycycline instead of azithromycin, so that's something to always be cognizant of. Or, again, you could do a fluoroquinolone if they're admitted to a non-ICU like levofloxacin, but most commonly it's probably ceftriaxone and azithromycin or ceftriaxone and doxycycline. You can consider some combinations even inpatient with Augmentin and things, but this is kind of most classical. Patients admitted to the ICU who are super sick, we usually empirically escalate therapy a little bit. You can just start with ceftriaxone and azithromycin or doxycycline in the right patient. And the right patient is that patient who has community-acquired pneumonia without risk factors for resistant organisms, right? So they don't have a risk factors for MRSA or Pseudomonas. They haven't had recent hospitalizations in the last 3 months with IV antibiotics. Those would be 2 risk factors for resistant organisms. So in our heads, the things we think about in these patients are, have they been hospitalized within the last 90 days? And if they had, did they receive IV antibiotics? If the answer is yes, then we usually put them on a broader regimen with something like Zosyn and vancomycin. Other things we think about is, in the last year, have they had a resistant organism, something like MRSA or Pseudomonas, just anywhere, right? If the answer is yes, again, we cover for that organism. But even in those critically sick, sometimes cap therapy with ceftriaxone and azithromycin can be reasonable if they are not an at-risk population for these more intense resistant organisms. Okay, if it's hospital-acquired or ventilator-acquired, it is a little different, okay? Local antibiograms are your best friend, but you really should think about covering MRSA with something like vancomycin. You can consider sending a MRSA NARS swab. There's some evidence that if the MRSA NARS is negative, which means the patient is not colonized with MRSA, that you could potentially DC the vancomycin. That strategy isn't perfect, but it's pretty good. And then again, you should cover for Pseudomonas. You can use cefepime or Zosyn in this case. This is actually double. So a regimen might be an anti-pseudomodal beta-lactam like Zosyn, and then MRSA coverage with vancomycin or linezolid. Duration of therapy, if it's uncomplicated community-acquired pneumonia, 5 days is typically reasonable. Some people do 7 days, but 5 days is typically reasonable. If it's hospital-acquired or ventilator-associated, we do a little longer, 7 days. And depending on how the patient's doing, you can extend that course, but 7 days is more guideline and what's recommended. We have a little kind of caveat here that if they're still really sick, you consider extending. But again, 7 days for ventilator-associated, 5 days for community-acquired. Both are reasonable regimens that are commonly used. Okay. So prognosis, you have pneumonia. What now? Well, the age and comorbidities of the patient does inform the mortality risk. So if you're older with comorbidities, you have a higher risk of death. Okay. If you're really sick, you have severe hypoxia, shock, multi-lobar disease. So if on chest X-ray you have multiple lobes that have infiltrates and consolidation, higher mortality risk. And then prompt antibiotics and good supportive care improves outcomes. These are all kind of obvious things, but just to speak it out loud. So most otherwise healthy patients fully recover from pneumonia. The vast majority fully recover. In hospital mortality, though, for those that require admission, so remember that means that someone had to be admitted, so they were a little sicker to start. Oh, wait, actually, we're misspeaking. Sorry. Mortality in general, if you are stable enough to be discharged home, mortality is actually less than 1%. The vast majority of those patients will do okay. If you did have to be hospitalized to the general medical floor, mortality is around 5 to 10%, right? So 1 in 20 or 1 in 10. This is probably a little high, but reasonable. And then if you admitted to the ICU with severe pneumonia, the mortality can be really high, 15, 20, 25%. So pneumonia can be really serious, especially in those who are really sick from it, or we're now blanking while we spell serious. That seems about right. Or those who are older with comorbidities, or those who are immunocompromised. All those patients are at higher risk to have a tough outcome. So how do we prevent pneumonia? Vaccination's a big one, right? If you have certain conditions, there's CDC guidelines. We're not going to dive into them here, but there's pneumococcal vaccines that prevent streptococcal pneumoniae, which is the most common cause of community-acquired pneumonia. Flu vaccines, COVID vaccines. There's an RSV vaccine now. There will probably be more vaccines related to this in the future. Smoking cessation, those smoking are higher risk for pneumonia. Good hand hygiene. And then if you're if you have at-risk patients, aspiration precautions too can be really helpful. So hopefully that was helpful. Let us know what thoughts, comments, questions you have. Definitely check out the channel. We'll upload this study guide and practice question to our Patreon page, so check that out. Again, weekly newsletter, YouTube members page for early access, and then podcasts and YouTube channel. We appreciate you all. Stay well, keep learning, and we will certainly see you next time.